Hi, this is Elliot Fishman, and welcome to our latest series of talks. And this is going to be on CT of the anterior mediastinum. This is one of the most classic topics, I think, in radiology, mediastinal imaging. We used to speak about it on plain films, and then when CT came along, CT really became the dominant imaging modality. So what I'll try to do is take you through some basic thoughts, show you lots of examples, discuss a lot of the common, mainly the common, but some of the uncommon things, and some of the findings that really help you make a very specific diagnosis. Now, in terms of protocols, we'll just make the point that the best way to look at the mediastinum is with IV contrast material. Typically an injection rate of 3 to 4 cc's a second, a scan delay usually of about 30 seconds, is going to work out very nicely. We'll use thin section CT. Most of the time, a single phase acquisition works perfectly. Occasionally, you'll do dual phase acquisition, perhaps in certain patients where you're worrying about vascular processes and trying to optimize venous and perhaps the arterial mapping. Perhaps there's a question of a possible thrombus in the heart or in the SVC or pulmonary arteries, and you're not exactly positive. But in most cases, a single phase acquisition works very nicely. You have to always look at the axials, the coronals, and sagittals. 3D mapping can be very valuable, but most of the time, if you look at the axials supplemented with coronal and sagittal, you're going to do great. The mediastinal masses, there's a range of them, and we've always been told that from the first day of residency. But they often have very specific appearances, but not always, and we'll talk about that. And then we'll talk about some of the pearls and pitfalls of the anterior mediastinum. And you can see the location. We talk about that being up front, behind the sternum, in front of the aorta, just classically shown on this diagram. When people do talk about the mediastinum and they give lectures, they classically will divide things into the anterior mediastinum, the middle mediastinum, and the posterior mediastinum. Sometimes people talk about the superior mediastinum, but usually it's those 3 points that tend to be most important. Now, in doing some work, looking up some topics, trying to update some information I had or questions I had, I did a search on PubMed and a search on radiographics, and I came across this article, CT of the anterior mediastinum, Spectrum of Disease. And if you look at it, that was published in 1994. Now that's like, 31 years ago. Some things have changed. If you look at the quality of the images in that paper, some things have really changed. But the challenges and the topics are in many ways very, very similar. We often speak about the mediastinum as something you would see on a chest x-ray. There's widening of the mediastinum and you're trying to figure out why. Things like thoracic aortic aneurysms or dissections, a markedly ectatic aorta. In a trauma patient, could the patient have aortic rupture? Could the patient have hilar adenopathy, be it due to infectious or inflammatory disease, TB, sarcoid, or malignancy like lung cancer? We look at mediastinum for possible masses. Which compartment are they in? Is it more likely a lymphoma or metastasis like a seminoma? Primary anterior mediastinum, things like a thymoma, or a neurogenic tumor more common in the posterior mediastinum? Could the patient have infection like mediastinitis? Or is it simply cardiac tamponade? Or is it related to underlying bony abnormalities, be they in the thoracic spine or in the sternum, whether it's from a tumor or it's from recent surgery? You can see the mediastinum really covers many different things, and we need to be really careful when we look at it. Now, you remember that when you were a resident, they told you mediastinal mass, 3 T's and an L, thyroid, thymus, teratoma, and then lymphoma. And wow, that seems simple enough or easy enough. And in many ways, it's still true. And so we'll supplement those 4 things but those are the ones that always should be crossing your mind when you're thinking about an anterior mediastinal mass. And you can see in this article, those are the top prevascular masses. Those are the key things. Then we talk about some other things maybe related to the heart, some unusual things, but that 3 T's and an L really have the rule of the house when you think about anterior mediastinal masses. So let's start with the thyroid. Most of the time with the thyroid, it's a very obvious process. Sometimes the thyroid extends substernally, could be on the right side or the left side or on both sides. It tracks down from the superior mediastinum down to the anterior mediastinum and sometimes middle or both anterior and middle. Sometimes you can't really connect it to the thyroid gland, and so it can be somewhat challenging. Goiters typically are benign processes, but they can cause symptoms. You can have a large goiter surrounding the trachea and causing narrowing, and the patients could have wheezing, for example, or can have retrosternal chest pain. Adenomatous goiter is the most common histology, with carcinomas occurring probably between 2 and 38%. Is a big gap, but probably well under 5%, and 2% is probably most likely. Thyroid tissues typically on non-contrast scans are of higher attenuation than soft tissue. That can be a very helpful sign. And when you give IV contrast, they're typically vascular. So that also is very helpful. When you look at substernal extension of a thyroid or a goiter, there's often multiple nodules present. There may be calcification, there may be cystic change, and there may be areas of hemorrhage, not active hemorrhage, but some high density zones from prior hemorrhage. And you may see all of them together at the same time. Here's a nice example of a large substernal thyroid in the anterior mediastinum. You see the enhancement, you see the cystic areas, you see the calcification, you see the mass effect on the arch and branch vessels. But this patient had some mild chest pain, which I'm sure had nothing to do with this goiter. Very nice appearance. You see the extent going up to the cervical region, nicely shown on the sagittal view. And if you looked at the chest x-ray, I think most of us probably would have guessed that this is thyroid, but you couldn't be sure. You could talk about a teratoma, you could talk about a thymoma. Remember when we did chest x-rays alone, it was very, very challenging. Now you would have had the chest CT, and you see the classic substernal thyroid, the calcifications, the cystic areas, and the relative enhancement with slight mass effect on the trachea as well. And here it is very nicely shown again as we follow it a little bit further. And again, they can be very large and can, as I said, cause symptoms occasionally, but most of the time it's going to be asymptomatic. Now, of course, most of these goiters are not going to be as large as in this patient. I mentioned about compression of the airway. Here you can see very nicely the trachea is compressed. There's substernal extension of the thyroid both on the right and the left, a little bit anterior, a little bit posterior as well. But you really can see how large and how impressive it is on the patient's trachea. Here it is on the coronal views. You can see it going from the cervical thyroid down. It pushes on the vessels. Classically, substernal thyroid is not going to invade any vessels. It's simply going to push things around. I guess if you had an anaplastic tumor within a substernal thyroid or in a goiter, you can see local vessel invasion, but that's exceedingly rare. And here it is very nicely on the sagittal view. And you can see, you can argue it's also maybe considered to be in the superior mediastinum. But since it comes down from the cervical thyroid, in most cases, that indeed always is going to be the path of travel. Now, when you mention thyroid, the thing we didn't say 3 T's and an L and a P, but one of the things you have to think about is a parathyroid gland. Now, parathyroid adenomas are going to be rare, okay? Ectopic parathyroid adenomas are going to be even less common. Typically, the parathyroid glands are located above or below the thyroid gland, And when they're in the mediastinum, they're considered ectopic. The inferior parathyroid glands are more commonly ectopic, located in the mediastinum in up to 5% of patients. Now, most of the time when you see an ectopic parathyroid adenoma, it's a few millimeters in size, and usually you tend to say, oh, that's probably a small node. Now, if the patient had symptoms of hyperparathyroidism, then you would think about it. Also, one thing about parathyroid adenomas, they're very vascular. That can help you as well. Patients with hypercalcemia include having symptoms of muscle pain, lethargy, nausea, constipation, and confusion. It's often a very, very difficult diagnosis and a challenging diagnosis. And again, remember, you have to look very carefully. Thin section CT with contrast. Look along the mediastinum. Look along the path of the vagus nerve and recurrent laryngeal nerve. And look also carefully within the thyroid parenchyma. It's a very, very difficult diagnosis. Now again, this article by Rupal Panchani does make several good points. It's an older article, but talking about the majority in the anterior mediastinum near the thymus, but rarely can be other portions of the mediastinum. I have seen several just by the aortic arch, often to the left of midline. So it kind of can be challenging unless you're thinking about it. We talk about parathyroid adenomas. Usually they're an isolated finding, but several genetic syndromes are associated with parathyroid neoplasms, including MEN type 1 and type 2A. So it's fairly uncommon. Hyperparathyroidism in these conditions is typically multiglandular, so it is kind of interesting. Remember, MEN2A is characterized by thyroid cancer, PHEOs, and parathyroid hyperplasia or tumors. So it is one of those P's that pops up when you talk about these different syndromes. Now, solitary parathyroid adenoma is a common cause of primary hyperparathyroidism. So if you're looking in a patient with primary HPT, you have to scan with contrast, good bolus from the neck down into the mediastinum. Okay, so it can be anywhere along the course. And again, they're typically going to be small, under a centimeter, and it can be very challenging. You need to find the lesion because going in surgically, if you don't know where it is, it's unlikely you're going to find it. So we talk also about using nuclear medicine studies. We also could talk about MR, but CT is often one of the most successful techniques for being able to find these ectopic parathyroid adenomas. Here's a good example. In this case, if you just tell me, look at the scan, I see the SVC. This is not a left SVC. It was only on a couple scans, and it's a centimeter or so in size. I would have said it's a small node. You could argue with me and say, how do I know it's not a thymoma? I guess I couldn't argue back, or I could argue back, but I couldn't 100% exclude that. But that was a parathyroid adenoma in a patient. We were looking for a parathyroid adenoma. But what's unusual about it, it's not very vascular. There it is to the left of the aorta, very nicely shown. And here it is on the 3D map. That's an ectopic parathyroid adenoma. But again, remember I said they're typically very vascular. This case breaks the rule. And that's one of the things in CT in general, but in the mediastinum, we have rules, but we have lots of exceptions to the rule. Another case, what about this patient? Looking for an ectopic parathyroid adenoma. There is a mass in the anterior mediastinum. That could easily be a thymoma. I would have no problem. And if I had to pick something, I would have said thymoma, enlarged node. I would have probably not even mentioned ectopic parathyroid adenoma, but that's what it was. And there's another example just in front of the left innominate vein, a 1 centimeter nodule, very nicely shown. Again, not enhancing to any great degree. You go through the differential, but when you have the clinical history, ectopic parathyroid adenoma, you can see it very nicely right there on the cinematic rendering. And I have a few more views to show that as well. Again, it's hard. You need to be very careful. It's a small lesion. It's indeed very, very challenging, whether it's axial or cinematic. But there it is on both of them, just really nicely shown on the cinematic rendering. Now, one of the things about cinematic rendering, it is very good in the mediastinum and many other areas. In the mediastinum, I find it helpful when you're looking at the relationship of masses to vascular planes, potentially for vascular involvement, potentially to help with preoperative planning. Another example, here's a 8mm ectopic parathyroid adenoma posteriorly positioned, almost near the esophagus. It's away from the thyroid gland posteriorly, but there it is. In this case, the enhancement, it really stands out nicely. So remember we said they're typically vascular. In this case, very nicely showing you the vascular nature of the lesion. Here it is on the cinematic rendering. Here it is from below on the cinematic rendering. And here it is in oblique position. You could see why finding this is so important. If you're the surgeon, you now know exactly where to go. You can really have a limited field of view, operate so the patient has less complications. If you don't know where to look, you're going to have a much wider area that you need to explore, and the surgical wound will be a lot larger. And it could be challenging both in at the time of surgery, but also as the patient recovers, and that area can scar very easily. If you really can know exactly where to go, you can really limit any problems. Here's another example. On the left side, it comes near the patient's carotid, somewhat low density centrally, but it is enhancing. You can see it again, its relationship to the carotid artery. Here it is again on the volume rendered views right there near the carotid. And again, just a really nice example. In this case, you also can see it's classic in that it comes near the bottom of the patient's left lobe of the thyroid gland. So I've now shown you a range of parathyroid adenomas, maybe more than you've seen in the last decade or so, but you can see they're small, typically but not always vascular. You can see their locations, but the locations will vary, and the importance of really looking very, very carefully. Now, in terms of the next topic, I'd like to speak more about the thymus gland, okay? So we talk about the thymus under those 3 T's and an L. The thymus is in every patient, right? Its size will vary. It's larger in children. It begins to atrophy over time. Usually patients over age 25, you don't see much of the thymus. But when you have thymic pathology, whether it's a child or an adult, there's a range of symptoms, tumors, and presentations. You can have chest pain, dysphagia, dyspnea, cough, hoarseness. It could be part of paraneoplastic syndromes. Always think about myasthenia gravis, red cell aplasia, a range of things. And again, we will use CT for detecting thymic pathology, but also following patients after they've had surgery. If I gave you a list of thymic tumors or thymic lesions, let's just go through them, and then we'll stop and look at them a little bit more carefully. We talk about benign lesions like hyperplasia, thymic cysts, thymolipoma, and an unusual type of thymoma, which is considered benign. Malignant, we talk about thymoma. That's at the top of our list. But also there's thymic carcinoma, rarely thymic lymphoma, and thymic carcinoid. We talk about metastasis, which are uncommon, Langerhans cell histiocytosis, thymic germ cell tumor, and follicular dendrocytic cell sarcoma, exceedingly rare. Now, one of the things we'll talk about is thymic hyperplasia because it's a great mimicker. I mentioned that the thymus is larger in younger patients and involutes over time. And typically you don't see it by age 25, and in most people by age 20. But in other times it can be large. And Thymic hyperplasia could look identical to a thymic malignancy, and it's one of the real challenges we face. But the other challenge we face right now is I've run out of time, so let's stop here, take a few-minute break, get a cup of coffee, get a soda, and I'll see you back here in 5 minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.